I was born and raised here in San Luis Obispo. I was away for the last 15 years, going to college and medical school and medical training. My last stop was actually in Houston, Texas, at the University of Texas at Houston Health Science Center, where I spent about 6 months out of the 3 years of my cardiology fellowship at MD Anderson Cancer Center. So that's how I kind of came to this topic, and I have a decent amount of experience with cardio-oncology or oncocardiology, or essentially the study of or the field of heart issues, cardiac issues in cancer patients. So we can get started here and talk about heart health after cancer care, or really, if we're being more accurate, heart health after a cancer diagnosis. So what do you need to know, what can happen, and how to start to address that as you start to recover? So first off, I don't have any disclosures, any relations to industry or anything. I'm just a simple country cardiologist who's trying to do good for his community. So why are we talking about this in the first place? All of you obviously have personal reasons to want to talk about this, but on a bigger level, it's an important topic because the FDA is approving new cancer drugs all the time. They're approving, last I saw, a new cancer drug every month. And so there's a dizzying number of advances in this field that we have to keep up with, and almost everything can affect them. On top of this, we have around 18 million survivors of cancer in the US. That's as of a year ago, which is a not insignificant portion of the population. There are a lot of people that this talk is relevant to. Unfortunately, among that group of people, the risk of developing cardiovascular disease of some sort is about 8 times higher than it is for the general population. And there's a statistic out there that about half of patients on chemotherapy have some form of cardiovascular disease after 5 years of treatment. Now, how much of that is because of the chemotherapy or the cancer, and how much is just basically it gets uncovered in the process of treatment is hard to say, but the fact is the risk is high. Finally, older cancer survivors in particular are more likely to die from cardiovascular disease than other causes. And so this is an important thing to making sure that someone who survived cancer actually gets to continue to survive for longer and live a quality life. So one of the big culprits in increasing this risk of cardiovascular disease in cancer patients is the actual treatment. Unfortunately, all these different great treatments we have, including chemotherapy, immunotherapy, some of these directed treatments that are out there, like tyrosine kinase inhibitors, radiation, all of these things can increase a person's risk for various cardiovascular conditions. And we'll get into a little bit more detail about what those are and what sort of conditions are associated with what sorts of medication classes. On top of that, cancer itself, a lot of different types of cancer, can increase your risk for cardiovascular disease. And so being knowledgeable about the direct effects of cancer and the effects of your treatment on your risk for heart disease is an important thing to keep in mind as you go through this process. So, what kind of things can happen when you have cancer or when you're being treated for cancer? What kind of heart problems can you get? One of the big ones is cardiomyopathy, or disease of the heart muscle. This is what's kind of colloquially known as heart failure. A lot of things can cause your heart to stop pumping as well when you have cancer or when you are undergoing chemotherapy, and it's a big one. In addition, there's other things. There's inflammation of the lining of the heart. When this becomes chronic, it can cause a heart failure type syndrome with shortness of breath and swelling of the legs and fatigue and weakness. Certain treatments can affect the valves in your heart and can affect the way that your heart functions, moves blood, and make it harder for blood to move through your heart. A lot of different cancers, treatments, and generally aspects of cancer care can increase a patient's risk for what we call heart disease, but coronary artery disease, plaque disease that affects the arteries that feed the heart and can actually limit the amount of blood flow that gets to areas of the heart muscle. Arrhythmias are a common complication in cancer, both because of the effects of the cancer and because of certain medications. And it's actually very common to see certain types of arrhythmias in oncology patients, and they can be a lot harder to control in some instances than they are in the general population. Additionally, high blood pressure is a big issue. Sometimes related to treatment, sometimes related to the cancer itself. Other less common problems include autonomic dysfunction, which can result in low blood pressure when standing, as well as dizziness when standing. Pulmonary hypertension, clots that form either in the arteries or in the veins and can actually break off and go down to the organs or into the lungs and cause additional problems. Certain treatments and certain cancers can increase your risk of peripheral vascular disease. So that same plaque disease that can affect the heart can end up in your peripheral blood vessels in your arms and legs and cause restrictions to blood flow, which can be symptomatic. And finally, an increased risk of stroke for the same reasons. For all of these reasons, the risk of stroke goes up. So, how do we get this? What are some of the relationships, things to know about, things to anticipate in your own treatment? So, chemotherapy does affect the heart. There are certain regimens that are very frequently used in breast cancer in particular that can be toxic to the heart. The classic one is what are called anthracycline-containing regimens. So anthracyclines are a class of chemotherapy drugs that have pretty bad toxic effects on the heart, especially if you exceed a certain dose in your lifetime. And so we are very, very careful about measuring how much per by weight a patient gets and really stopping the dosing beyond that point. These are people who will frequently get echoes on a regular basis, ultrasounds of the heart, to look at the heart's function and try to catch as soon as the heart function starts to deteriorate from toxicity, because you don't want to give any more at that point. These drugs have other names, including the common one being doxorubicin. There's also daunorubicin. There's a few names kind of like that. So if you've been on a doxorubicin containing regimen, whether it's for breast cancer or lymphoma or leukemia, this is a consideration that has in mind and that you should be thinking about as well. There is another class of medications that are used in breast cancer, which targets certain receptors. So in HER2 plus breast cancer, there is a drug called trastuzumab or Herceptin that can also cause heart failure or cardiomyopathy. The difference with the other medication I mentioned is that trastuzumab's heart failure is often reversible. So when you stop the medication and you treat heart failure, the heart's function can improve. So again, if you are on Herceptin therapy for your breast cancer, this is something you want to make sure you've asked your oncologist about and that you're being watched for and you know what symptoms to be looking out for to alert your oncologist or cardiologist. So those are sort of the classic chemotherapy regimens that cause heart failure and cardiotoxicity. Unfortunately, we see this with a lot of other chemotherapy regimens as well. Less regularly, less consistently, but almost any chemotherapy regimen can be toxic to the heart. And so more and more, in a lot of places, before starting any chemotherapy, oncologists will try to assess a patient's heart function and keep track of it through chemotherapy to make sure there are no complications. So again, anytime you're starting chemotherapy, you may want to bring this question up of, do I need any screening for my heart function while I'm undergoing this treatment? So how do we do this? There are two ways. One is far more practical than the other, especially around here. That is serial echocardiography. So every few months, you get an ultrasound of your heart. In a lot of places and with a lot of regimens, that would be an echocardiogram before starting chemotherapy, and then before each subsequent cycle of chemotherapy. And based on the results, if the heart function is down, then you would stop, we would not give the next cycle, and we would move to a different type of treatment. Echocardiography or ultrasound of the heart lets you see the size of the heart, how well it's squeezing, and look at a lot of other structures and function. That helps guide treatment. It helps tell you when someone has cardiotoxicity and when you need to start them on heart failure medications to prevent further deterioration. The other is a type of nuclear scan, so using radioactive tracer called MUGA. It's more of a historical note, and we really don't use it in most places. There are a few academic centers that still use it. Here in San Luis Obispo, we really don't have that type of imaging available in the first place, so it's not relevant to us. Now, I mentioned that the immunotherapies can also have some ill effects on the heart. So immunotherapy is a new emerging type of way to treat cancer. That is a variety of drugs that sort of unleash the immune system on cancer. So they sort of activate your own immune system to go hunt down cancer cells and kill them. The downside, it works very well for a lot of people, but the downside is that by unleashing your immune system, you can actually make it attack normal tissue as well. And unfortunately, in some cases, the heart can be a target of this. So what this can result in is myocarditis or acute inflammation of the heart. It's not common, it's actually pretty rare. And with these medications, we don't see a lot of cases of myocarditis, but it does happen. And when it happens, it can be very severe. So in particular, this is associated with certain drugs called ipilimumab and nivolumab. And they're used for a variety of different cancers. And if somebody's going to be started on these medications, again, they need an echocardiogram beforehand to make sure they don't have any underlying heart problems. And they need to be watched closely. Both the patient and all their healthcare providers need to be aware that this complication can occur. We don't, unfortunately, have good ways to screen for it once you're in treatment. We don't have a reliable way of knowing, or it's not reliable that after a certain amount of time you may have, you may develop myocarditis or whatever. It's unpredictable. And so to a large extent, we have to give these treatments and then react once somebody becomes symptomatic. Because this is such a new condition and a new class of drugs, we will hopefully over time start to get more data on this and start to be able to develop some screening protocols. The same thing goes for treatment, actually. It's not established. Once you have a case of myocarditis from an immune checkpoint inhibitor, how best to treat it and evaluate it. That's starting to develop. There are groups in academic centers that are starting to define this and establish protocols, and those will hopefully be making their way out to the rest of the community and to the rest of the country sooner than later. So this is an emerging area, and it's something that hopefully, perhaps the next time I give this talk, we will have more information. But as of now, this is just something to be aware of. And if you start to have heart failure symptoms, we'll go over what those are towards the end of the talk. You really need to let your doctor know. So there are also hormonal therapies that are very common, especially in breast cancer, but also in ovarian cancer and less relevant here, but in prostate cancer for men. Certain medications, especially the ones that target estrogen in breast cancer, can worsen or accelerate plaque disease in the heart and in the peripheral vessels. In particular, the drugs anastrozole and letrozole, which are very commonly used, can actually make these plaques grow bigger and become more severe pretty quickly. In particular, in people who already have underlying coronary artery disease. So in women who don't have disease, the risk doesn't go up that quickly. But if a woman has plaque in their heart and they go on one of these medications, it's not uncommon to see worsening symptoms like chest pain and exertional intolerance stemming from the hormonal therapy. So again, when you're going on these things, it's important to make sure that you are addressing as many risk factors for the underlying coronary disease as possible to reduce your risk. Again, we'll talk about this towards the end of the talk. So I mentioned arrhythmias, they're very common. In particular, atrial fibrillation, which plenty of people have heard about and see commercials for blood thinners for on TV. Very, very common in cancer patients. In addition, other arrhythmias like supraventricular and ventricular tachycardias are also common. These are various arrhythmias that go fast, whether they come from the top chambers of the heart or the bottom. They go fast and they can be symptomatic with your heart racing, with lightheadedness, and they can be difficult to control. There are certain chemotherapies and other treatments that are associated strongly with the onset of, in particular, atrial fibrillation. And that's these class of medications called tyrosine kinase inhibitors. That's things like ibrutinib, which goes by a brand name now that I don't actually remember, but it's used in the treatment of certain types of leukemia. And it's a pill that helps keep it under control for a long time. Unfortunately, when treated with this medication, people can go into atrial fibrillation and sometimes need to go off of it. So if you are on one of these medications and you start having heart palpitations, shortness of breath, lightheadedness, fatigue, and exertional intolerance, you may want to have your doctor do, or you should have your doctor do an EKG to make sure that this is not going on. Additionally, arrhythmias may indicate other serious underlying conditions, both from the heart and related to the cancer. So if somebody has developed heart failure, for example, cardiotoxicity from their chemotherapy, they can actually manifest, they can present with an arrhythmia first before they have any other symptoms. Same thing with the myocarditis I was talking about. Sometimes an arrhythmia is the first sort of sign or symptom of it. So this is something that needs to be taken seriously. No matter what kind of treatment you're on, if you start noticing that your heart's racing and skipping beats, it needs to be evaluated, at least with an EKG. So make sure that you talk to your doctor about this and you notify them and have them evaluate it if it happens. Blood clots are another big one. Blood clots are associated in general with cancer. Cancer patients are considered to have a much higher risk for blood clot formation. So certain cancers in particular really raise the risk of blood clots in the veins and in the arteries. These can include pancreatic cancer and other cancers of the internal organs of the abdomen, like stomach cancer, gallbladder cancer, liver cancer. There are also certain chemotherapy treatments that increase the risk for blood clot formation. These are based on a medication called 5-fluorouracil or 5-FU. So if you are on one of those regimens, again, you want to make sure you know you are aware of what symptoms to look for that could indicate you have a blood clot forming. The problem with a blood clot in your legs or your arms is that if a piece of it breaks off, it can go up into your lungs and cause a pulmonary embolism, which can be fatal in some cases. So it's important if you are starting to have symptoms of a blood clot in your veins, that it gets checked out. It's also complicated in treating these because not all blood thinners are as effective in cancer patients. And so it is important that if whoever is diagnosed that and is trying to treat it with blood thinners is aware that you have cancer, because it affects how we treat it. On top of this, many cancer patients, whether they have a leukemia or lymphoma or undergoing treatment with chemotherapy, can have low platelet counts or other clotting abnormalities that put them at higher risk for bleeding, which makes it even more complicated to treat these blood clots when they form. So you want to be in touch with your doctor. You want to make sure that you have kind of a team approach to this, and that if somebody else is taking care of this or in the emergency department being taken care of, they know that you have cancer. Now, I mentioned that radiation therapy can affect the heart. This is a picture of the heart on an echocardiogram, and you don't need to worry too much about the structures, but there is this thick, I don't know if you can see my mouse. Yes, you can. There's this thickening of these structures. These are two of the heart valves. And take my word for it that they're thicker than they're supposed to be. This is a common and classic effect of radiation on the heart. Because the radiation destroys the tissue, your body reacts to that by basically forming scar tissue in those areas. And so the valves become scarred and stiff, and they don't work as well as they should. Blood can't flow through them as well as it should. Sometimes it leaks backwards. These can cause a lot of symptoms. A lot of times, these valvular problems in the heart are delayed. So you may get radiation in your 30s for Hodgkin lymphoma and not have valve disease until 40 years later. So not all patients who get radiation are as high of a risk for this, because if you get it later in life, you may not have that. You may not have 50 years to live if you get radiation in your 70s. But it is something to be aware of. And especially if you're a younger person who has gotten radiation when you were young in your 30s or 40s or younger, or is going to get radiation at that stage of life, this is something that you want to keep in mind. And in the future, if you're seeing a cardiologist, you need to make sure that they know that you've had radiation therapy. Now, this is particularly radiation therapy to the chest, not radiation to other parts of the body. But when you're getting radiation for lung cancer, breast cancer, thyroid cancer, anything in this area above the waist, that's when it's really a big risk. There are other issues that arise from chest radiation that can affect the heart as well. So in the same way that the estrogen blocking medications can accelerate plaque formation in the heart, radiation therapy can do the same thing by damaging the lining of the blood vessels, making it easier for plaque to form. It can also cause thickening and stiffening of the lining around the heart, which makes it harder for the heart to expand when blood is coming in, and can cause some significant symptoms of heart failure like shortness of breath and exertional intolerance, and can be quite difficult to treat. These things are rare, fortunately, and radiation therapy has gotten a lot better over the years at minimizing the collateral damage. So nowadays, radiation oncologists are very good at targeting the radiation beams in such a way that they minimize how much they pass through the heart and through the other tissues, and they just hit the tumor. So this hopefully will be less of an issue in the future, but it's still a consideration. And so again, it's something to keep in mind. Then there's the question of how cancer itself affects the heart. First of all, many cancers can actually send metastases into the heart. In particular, we see this with lymphomas, cancers of the gastrointestinal system, and kidney cancer. So they can spread through the veins and through the lymphatic vessels, and they end up in the heart, and they can actually affect the heart's function just by having a massive cancer in the heart muscle. So this picture down here next to me is an MRI of the heart, and there's this white sort of lump in here, and that is a metastatic lesion from cancer. I don't know what type of cancer, but that's something that we do actually see fairly often. In addition, cancer itself creates a high inflammatory state in your body, and that can result in certain conditions, including, again, accelerated plaque formation in the heart and the heart's arteries. It can also cause inflammatory fluid collections around the heart that can affect the heart's ability to fill with blood and to pump, and can become severe and symptomatic enough that we have to stick a needle in that fluid collection and drain it because the patient's blood pressure is too low or they can't breathe. This here is a CAT scan showing that exact condition. So here's the heart, and then there's this big fluid collection all the way around the heart. And we can see this in a lot of breast cancers, including a lot of cancers, including in particular breast cancer, as well as lymphomas, leukemias. Those are the most common ones, but again, you can see it in many cancers. A lot of cancer patients can also get just acute inflammation of that lining around the heart without the fluid collection. That can result in chest pain and chest discomfort, and needs to be treated with anti-inflammatory medication. Finally, certain cancers, in particular multiple myeloma and other blood cancers, can cause the accumulation of a protein called amyloid inside the heart muscle. And it results in thickening of the heart muscle and stiffening and dysfunction, and can cause a heart failure syndrome. So heart failure symptoms, which we'll talk about again, and is actually very difficult to treat and very difficult to diagnose. So this is something that does get seen, and if you do have multiple myeloma or another blood cancer, it's something that you need to be aware of, and you need to make sure that your doctors know you have this history and that they're thinking about the possibility that you have this disease underlying if you develop symptoms. Unfortunately, we don't have great ways to screen for it, but the biggest part of that battle is knowing to look for it in the first place when someone has symptoms. So I think I've probably just laid a lot of very scary information on everybody here. So the question is, what can you do about it? What can we do about it as the medical community? What can you do about it as a patient who has cancer or as the loved one of someone who survived cancer? So in the conditions where we can do this, screening before treatment is very, very important because it identifies who can get certain chemotherapy regimens, who needs an alternative. It helps us find things before they become advanced and symptomatic, and hopefully treat them before they become irreversible. So how do we do that? In certain conditions, we do a pre-treatment risk assessment. We talk to a patient, find out what risk factors they have. Do they have high blood pressure, high cholesterol, diabetes, family history? You may do an echocardiogram before you start chemotherapy, as I mentioned, to see how the heart is functioning at baseline and know how much kind of reserve it has to get poisoned by the chemotherapy without losing its function. And if it is already weak, to use an alternative chemotherapy. We also can do blood work in certain conditions to look at biomarkers for damage to the heart, chronic damage to the heart. This is sort of an emerging area, and there aren't a lot of tests yet that are widely available, but I think it's something that's coming down the pipe, and hopefully in a few years will be more widespread. Maybe the most important thing here is risk factor modification. So for people who don't have known already diagnosed heart disease, it's very important to try to address and control any risk factors that increase a person's risk for developing plaque in the coronary arteries, heart failure, arrhythmias, blood clots, etc. In particular, I mentioned a number of different things that can increase a cancer patient's risk for developing plaque disease in the heart. So it's very important for anybody who's being treated for cancer or has survived cancer to be sort of aggressively controlling blood pressure, cholesterol, avoiding smoking, avoiding excessive alcohol use, eating healthy, watching your food portion sizes to not gain too much weight, and exercising regularly. All of these things can contribute to the formation of plaque in your heart and symptomatic plaque disease that then requires bypass surgeries and stents and all of these things that we as cardiologists do. So the best way to avoid needing a cardiologist is to take your medications and for your doctors to be very aggressive about treating those risk factors. Get into that more in a minute. We also can try to reduce the rates of these diseases by modifying our treatment protocols on the physician end of things. So this is why I say, making sure that you've asked your oncologist, when I'm doing this chemotherapy, what happens if I have worsening heart function? How are you going to monitor that? Because if it happens, the oncologist may need to change your chemotherapy and remove certain drugs that are the highest risk. And it's very important for your oncologist to be, and your other doctors to be open to doing that, to have a plan B, to not delay treatment, to not take you off treatment for a long time, and to change your treatment as quickly as possible if it needs to happen. So it's a good idea to press your oncologist to know what their plan B is if choice A doesn't work out well for your heart. And then for certain conditions, it's important to treat them early. So, for example, we do these serial echocardiograms to look at the heart with certain chemo regimens to make sure that the heart function is not decreasing. It's not enough just to look. When the heart function starts to decrease and we start to notice the first signs, it's important to start the medications that we give to anybody who has heart failure that help to prevent deterioration of the heart's function. We have a whole bunch, like 7, 8, 9, 10 different medication classes these days that we use in people with heart failure that help to prevent worsening of the condition. It's important that if this is identified in a cancer patient, that we start that as soon as possible. We don't wait until they're symptomatic. This is how you can keep someone feeling well, even if they have some toxicity and some damage to their heart. Stop the process and keep them feeling well and living a normal life. So what can you as the patient do to protect yourself? As I mentioned several times, make sure your oncologist knows about any cardiac risk factors you have. So any personal history of heart problems, they need to know about. Any history of high blood pressure, high cholesterol, tobacco use, any family history of any cardiac conditions, alcohol use, drug use, anything else. And then again, a detailed family history. If you have multiple family members who developed heart failure, chances are that if you get chemotherapy, you're more likely to develop heart failure as well. There may be something that runs in the family that predisposes you to this. You have multiple family members who've had heart attacks, then it's important that any risk factors that you found are treated as aggressively as possible, because again, you may have some family history, genetic condition that predisposes you to plaque disease forming in your heart and arteries. As I mentioned before, lifestyle modification is important because this is a big part. This is about 50% of how you reduce those risk factors that I talked about. Exercise is important. Exercise keeps you in better shape. It keeps you strong. It helps your heart to stay strong and your heart's circulation to be as robust as possible. In people who are more active or in better shape, even when they develop heart disease or heart failure or arrhythmias, they feel better, they tend to do better, they tend to live longer with fewer hospitalizations. This is really important. A healthy diet and weight management are also very important in this. When somebody is overweight or obese, their risk of diabetes, high cholesterol, high blood pressure goes up. So watching what you eat, watching how much you eat, as sort of boring or difficult as that may sound or be, is really important to having a good outcome, both from cancer and from any related heart conditions. This is another huge one, is taking preventative medications if you need them. So if your doctor, whether it's your oncologist or your primary care doctor or your cardiologist, tells you you need a statin or a blood pressure medication or aspirin, you need to take them. As a cancer survivor, your risk is much higher than that of the general population. There's no, I want to try to diet my way out of my high cholesterol. If they think your risk is high enough that you need a statin, unless you have severe side effects to the statin, you should be taking them. These medications are lifesavers. They will prevent plaque formation. They will slow down plaque formation. And they will keep you from having a heart attack. Blood pressure, same thing. By controlling your blood pressure and taking your medications as directed, you can reduce your chance of developing heart failure, of developing stiff heart, of developing arrhythmias. And aspirin, again, for preventing heart attacks is very important in cancer patients who are higher risk. Now, not everyone necessarily needs these medications. If you are somebody who has low platelets because of chemotherapy or leukemia, aspirin may not be an appropriate medication for you. But if it's recommended, stick to the program. This is how we prevent heart disease, serious heart disease in cancer patients. Final thing is paying attention to your own symptoms and reporting them promptly if you have them. So we'll go over what some of the symptoms are to watch out for. Excuse me. And it's important that you watch for them and you pay attention to them, but it's not enough just to do that. If you start to have them, you need to report them to your oncologist or your primary care doctor, or if you're seeing a cardiologist, to your cardiologist. Ideally, you'll report them to everybody. Make sure that somebody does something about it. It may be that you have some of these symptoms and it's not heart related, but it should be evaluated instead of just assumed. So what symptoms do you watch out for? Maybe the first thing that will happen when someone has a heart problem that is progressing slowly is that you won't be able to exercise as much as you could before. So if you notice that I can't walk as far as I could 2 months ago. 2 months ago, I could walk up a flight of stairs, and now I get short of breath or I get chest pain halfway up those stairs. That's cause for concern. Now it gets confusing because for people in particular who are on chemotherapy, it can just be a side effect of the chemo. But you still want to be reporting that, whether it's because of chemo or your heart. It's not normal to become fatigued that way climbing upstairs. Especially for those people who are in good shape before treatment or before a cancer diagnosis, this is a big early sign that something's not right, whatever the cause is. Other things that are signs of heart disease, then again, can be seen in a lot of different non-cardiac conditions, including shortness of breath, chest pain, heart palpitations, which means the sensation of racing or skipping heartbeats, swelling or redness of the legs. This can be a sign of both heart failure and also a blood clot formation in the veins of the legs. So if you have one leg in particular, you have, say, your left leg becomes swollen, red, painful, warm to touch. That's a classic indication that you may have a blood clot in your legs, and that needs to be evaluated. Now, that can also be due to an infection, but again, either way, that needs to be evaluated, so you don't want to ignore that. Lightheadedness is a big one. Again, can be caused by all sorts of things, but it may warrant an evaluation for cardiac conditions. And then if you have sudden loss of consciousness, again, that can be a big one, and that usually warrants some form of cardiac evaluation, whether that's an EKG and a heart monitor, or an echocardiogram, or both. These are some of the things to watch out for. Now, a lot of people ask about these wearable technologies, we call them. Smartwatches or other devices that allow you to monitor your heart rhythm and your heart rate. These include the Apple Watch, Fitbit devices, and the Cardio Mobile. And the Cardio Mobile is the one in the middle here with the 2 fingers on it. So they can be helpful in some people because they can help catch an arrhythmia quickly. So for something that doesn't last a long time, lasts a few minutes, if you have one of these, you may be able to get a simple EKG of it and send that to your doctor and say, look, I'm not in a normal rhythm when this happens. And sometimes when they're used a certain way, they can catch arrhythmias that aren't even symptomatic, but may need to be treated. The downside to these is that they can cause a lot of anxiety. Let's be honest, a lot of people who have been through cancer and chemotherapy are inherently going to be affected by that experience. And many people do have some serious health anxiety and get very concerned that there could be something new happening. And there are people who start using these devices and they kind of go down the rabbit hole and make themselves miserable, looking for something that is either not there or is not significant, and trying to fix something that doesn't need to be fixed. And so whether or not to use these technologies really needs to be an individual decision. They can be useful, but they can very much hurt your quality of life. And there's no point being miserable trying to monitor every single heartbeat you have if it makes your life, if it's not allowing you to enjoy your life the way you should after you've survived cancer. So I think it's very important when considering one of these for you as the patient to know yourself and to kind of anticipate, if I do this, I might get too anxious and I might go down the rabbit hole. And if that's the case, maybe don't use it. Keep it away. And I think it's important to consider, none of these companies develop these devices out of the goodness of their heart. Apple developed its watch with an EKG on it to sell you their watch. So they don't want you to be calm about it, they want you to be anxious about it. So if you're somebody who's prone to that, you may want to consider not using these, even if it means you might miss some arrhythmias. It's okay. If your life is not enjoyable, if you're miserable and anxious all the time, you're not doing yourself any good. You're not making the most of the life you've been given with your cancer treatment. So I think this is a really important thing to think about, especially as these become highly advertised. So that's what I've got for you all.